Hello friends, today we are going to discuss the recall based pharmacology questions of AIIMS November 2019. Starting with question number 1, a patient was given ampicillin 2 gram intravenously. After that, the person developed rash, skin, hypotension and difficulty in breathing. This patient should be managed by. So we have a history of administration of ampicillin followed by rash, hypopigmentation and breathing difficulty. We are looking at a case of anaphylaxis. So the question is basically asking treatment of anaphylaxis. Now in treatment of anaphylaxis, first of all, the drug of choice is adrenaline. So we need to see how many options provide adrenaline. We see all the options are about adrenaline. So remember, adrenaline is the physiological antagonist of histamine. Anaphylaxis is caused by histamine. The main mediator is histamine, and adrenaline is drug of choice because it is the physiological antagonist of histamine. So that is the number one thing to select the drug to be used. Second, the concentration to be given. Concentration would depend on the route of administration. So what is the route of administration? That also we need to consider. So the route of administration of adrenaline in anaphylaxis, the preferred route is intramuscular. Intramuscular is the preferred, the best route, followed by subcutaneous, and if the condition is unresponsive, then as the last resort only IV adrenaline can be used. So this is the route. So we are looking at adrenaline given intramuscularly. So out of the given options, option number A and option number C, they are given as intramuscular. Now we come to the concentration. The concentration when intramuscular route is used is 1:1000. 1:1000 is the concentration given. So now we have 1:1000 as the concentration, route as intramuscular and drug as adrenaline. 1:1000 adrenaline intramuscular route. So we can see that our answer, the correct answer to this particular question will be option number A. But this question or this property of adrenaline uses has been asked many times. So let's try to revise in totality. So the uses of adrenaline, number one, anaphylactic shock. We are looking at uses of adrenaline. What is the route of administration? What is the concentration? And what is the dose? Three things we will summarize. So in anaphylactic shock, the preferred route, as I have told you, is intramuscular. Intramuscular, the concentration given is 1:1000. Please understand that this means 1:1000 means 1 gram is dissolved in 1000 ml. 1 gram, that is 1000 milligram dissolved in 1000 ml. So this actually means 1 milligram per ml. That is the meaning of 1:1000. So intramuscular 1:1000 and the dose is 0.5 ml. That means we are giving 0.5 milligram because 1 milligram has 1 ml, so half ml will have half milligram. So in anaphylactic shock, this is the preferred route, preferred concentration and the preferred dose. However, if the condition is not responding to intramuscular and if we decide to use intravenous, then please remember that 1:10,000 should be the dilution. Now you have to dilute adrenaline 10 times, 1:10,000 has to be diluted 10 times and only then it will be given as intravenous. So this is about adrenaline in anaphylactic shock. The next important use which is asked and pretty confusing to students is cardiac arrest. In cardiac arrest, the preferred route will be intravenous. It will be given intravenously. Whenever we give intravenous, the concentration of adrenaline has to be 1:10,000. 1:10,000. 10,000 is the concentration in cardiac arrest when we give IV, and the guidelines say that 1 milligram of adrenaline should be given. The dose is 1 milligram now. So 1 is to 10,000 means 0.1 milligram in 1 ml. And since we have to give 1 milligram, so approximately 10 ml of the solution will have to be injected. So this is the concentration, route and the dose of adrenaline for treatment of anaphylactic shock and cardiac arrest. Very commonly asked questions. Second question, which of the following is not used in heart failure? Now this is a simple question if you understand, but a lot of students have marked the answer wrong as metoprolol because they thought or they remembered that beta blockers are contraindicated in CHF. That statement is partly correct. Beta blockers are contraindicated only in acute CHF, not in the stable or the mild to moderate category of CHF. So metoprolol is not the right answer. So let's look at the treatment of CHF and you will find which drugs can be used. So CHF treatment is divided into acute CHF or chronic CHF. So first let's look at the treatment of acute or what you call as decompensated CHF. In this, there is left ventricular failure which can result in pulmonary edema. So decompensated heart failure or left ventricular failure results in pulmonary edema. So first thing that you should give is IV furosemide. So we give IV furosemide to shift the fluid from lung to systemic circulation. This is followed by morphine. This is followed by morphine. So morphine will calm the patient, decrease anxiety, and it will also shift some fluid from lung to systemic circulation. So morphine is the second drug to be given in acute CHF or left ventricular failure. Third, you have to give intravenous vasodilators. So the third category of drugs to be used are IV vasodilators. Now how to remember which vasodilators are used? You can remember by the mnemonic, simple mnemonic 3N. 3N, all the names will start with N. So we have nitroglycerin which can be given. We have nitroprusside which can be given, and we have the third drug as nesiritide. What is nesiritide? Nesiritide is a recombinant BNP, brain derived natriuretic peptide, natriuresis and vasodilator. These are the two things nesiritide cause. It's a vasodilator given in acute CHF IV as mentioned. So this is the third class of drugs used in acute CHF, IV vasodilators, which are remembered as 3N. Then after, if the patient is not benefited by this treatment so far, then the fourth type of or the class of drugs to be used in acute CHF are the positive inotropes. Positive inotropes, and since we are looking at acute condition, these are the inotropes which will be given intravenously. So intravenously given inotropes. Now which drug should come to our mind? We have dobutamine which can be used. We have dopamine, and the third one is noradrenaline. So these three catecholamines which we know are given only intravenously are given as positive inotropes given intravenously. What are the other inotropes that can be used? Phosphodiesterase type 3 inhibitors like milrinone. They can also be given. Then there is a new inotrope, new drug that is known as levosimendan. Levosimendan is a calcium sensitizer, which also acts as inotrope, that can be given. And lastly, although it is not very commonly used nowadays, but even digoxin can be given intravenously. So these are the drugs that will be used in treatment of acute CHF. The treatment of acute CHF is intravenous. So all these are intravenous drugs, and out of which in the options we can see nesiritide is given. So nesiritide is a recombinant BNP and it is used in treatment of CHF. So we can rule nesiritide out. Then we come to treatment of chronic CHF. So patient is having mild to moderate symptoms, he is stable, symptoms. How do we treat this? Number one, patient is having basically congestion, and the best drug to get rid of congestion are diuretics. So furosemide or thiazide. Orally these drugs now will be given because it's a chronic condition. So furosemides are better, followed by oral thiazides. So diuretics are the best drug. Secondly, we will give this patient ACE inhibitors. ACE inhibitors, or we can say angiotensin receptor blockers, they will also be given to decrease the remodeling. And you know the names of ACE inhibitor or ARBs, they end with either pril, enalapril, captopril, or sartan, losartan, valsartan. If patient is not controlled by these drugs, combination of these drugs, then the third class of drugs come into picture, and they are beta blockers. Beta blockers are given, they decrease long-term mortality. Three beta blockers are most favored. The most important and most commonly used is carvedilol. This is the most commonly used beta blocker, followed by the one which is given in the options, metoprolol, followed by bisoprolol. So these are the three beta blockers which can be used in stable chronic CHF. Beta blockers, please remember, are contraindicated in acute or decompensated CHF, as we have seen above. In acute condition, we are giving dopamine, dobutamine, noradrenaline, which are beta agonist. So beta agonists are given intravenously in acute CHF. Beta blockers are given orally in mild to moderate or chronic CHF. Patient, if not controlled, then we have some add-on drugs nowadays. If patient is not controlled on these three kinds of drugs, then what can be added? Number one, we can add digoxin. So digoxin mainly today is an add-on drug in treatment of CHF, added if patient is uncontrolled on diuretics, ACE inhibitor and beta blocker combination. Then we can add a combination of sacubitril plus valsartan. So sacubitril is a new drug for treatment of oral treatment of chronic CHF. What is sacubitril? Sacubitril is a neprilysin inhibitor. Neprilysin, also known as neutral endopeptidase, both are same names. Neprilysin inhibitor or neutral endopeptidase inhibitor, it prevents degradation of BNP. Orally given drug, combined always with valsartan. Further, what also can be added? We can add spironolactone also, or we can add a combination of hydralazine plus isosorbide dinitrate. So 1, 2, 3, 4. Digoxin, sacubitril plus valsartan combination, spironolactone or hydrolyzine isosorbide dinitrate combination, any of them can be added if patient is unstable or cannot be maintained by combination of the first three drugs, diuretics, ACE inhibitor and beta blockers. These are the drugs which are used in treatment of CHF. Remember, chronic CHF has stable symptoms, treated orally, and beta blockers are used, while acute CHF treatment is given always intravenously and beta agonists are used. So we have discussed all the drugs. Now we can look at the question which is not used in heart failure. Metoprolol is used, sacubitril is used, neseritide is used. So what is not used in treatment of CHF is trimetazidine. Trimetazidine is a, as the name suggests, meta. Meta should remind you of metabolic modulator. It is a metabolic modulator or partial fatty acid oxidation inhibitor. Partial fatty acid oxidation inhibitor used for treatment of angina. So trimetazidine is a partial fatty acid oxidation inhibitor or metabolic modulator used for treatment of angina, not for CHF. Moving on to question number 3. Which of the following is a Schedule X drug? Now, first thing that we should be very careful, that some students have confused this question Schedule X with Category X. Category X is a classification of drug in pregnancy. So category X drugs are absolutely contraindicated in pregnancy, but that is different from schedule of drugs. Category X drug out of these is thalidomide, but that is what is not asked. So a common mistakes has been, while answering this question, is to tick thalidomide as the answer, thinking that it is a category X drug which is asked, which is not the case. So thalidomide is not answer for this question. What is this Schedule X? Now in last 2-3 years we have seen that couple of times question have been asked on schedule of drugs. So we need to understand what is this drug schedule. So in India we have a Drugs and Cosmetic Act. Drugs and Cosmetic Act, which was passed in 1940. So this is a part of Indian Constitution. This is a law in India passed by Indian Parliament, first passed in 1940 and later on amended several times. This lays down everything about drug regulation in India. Now this has various parts, we need not go in great details, but this Drugs and Cosmetic Acts has various schedules which are part of it. They are like chapters to this particular act, and some of those schedules have been asked many times in the recent past. So what we should know? Number one, we should know there is something called Schedule H drugs. So this was the first question that was asked 2 years back. Schedule H drugs. These are the drugs which are to be sold on prescription of a registered medical practitioner. So pharmacist or the one who is having a medical shop should sell these drugs only when the patient is able to produce a prescription of a doctor or registered medical practitioner. All such drugs are placed in Schedule H of Drugs and Cosmetic Acts. Then there is something called Schedule X. Now this has been asked in this exam. So what is Schedule X? It includes narcotics plus psychoactive drugs. So all narcotics and psychoactive drugs are put in Schedule X of Drugs and Cosmetic Acts. Now in this, all provisions of Schedule H will apply. So all provision of Schedule H will apply. That means they are also to be sold on prescription. But in addition to that, pharmacist has to maintain the record of sale and copy of prescription. So record of sale and a copy of prescription has to be maintained for 2 years by the medical shop owner or the pharmacist. So all narcotics and psychoactive substances are put under Schedule X. Now what are the important examples of drugs that are covered in this schedule? So one is barbiturates, then we have amphetamines, then we have ketamine, and we also have various other drugs like methylphenidate and phencyclidine. All psychoactive substances are placed in Schedule X. So this is what has been asked. Based on this, now you can attempt the question. Schedule X drug out of the one will be ketamine. So answer is ketamine. One more schedule that you should know is Schedule K. Schedule K includes all the home remedial measures, household remedial, or what we call as over the counter, which can be sold without prescription. They are covered in Schedule K. Schedule K includes drugs like paracetamol, drugs like aspirin, and even quinine, which has been traditionally used for treatment of malaria over many generations, is also part of Schedule K. So Schedule H was asked, I think 2 years back. Schedule X has been asked, so maybe that in the coming exams they ask something more. So Schedule K is an important thing to remember, over the counter home remedial measures. Moving on to the next question. Question number 4 says that a patient presented to emergency with overdose. So first we highlight the word overdose. We are looking at a drug overdose of some drug. Increase in salivation, increased in bronchial secretion. So secretions have gone up along with meiosis. Now meiosis is always an important feature. On examination, blood pressure was low, RBC esterase level is given. What should be the treatment? Without looking at any other thing, just focus on meiosis first of all. Meiosis or pinpoint pupil, also said to be non-reactive to light. Pupil is highly constricted. When you throw light, it does not react. Pinpoint pupil, highly meiotic pupil. The moment this is present in a case, we are looking either at O. O stands for opium or opioid, or organophosphorus, or we are looking at P, which is phenol or pontine hemorrhage. These are the situations where pinpoint pupil can be present. Opium poisoning, organophosphorus poisoning, phenol poisoning, or pontine hemorrhage. Since the drug is also causing increase in secretions, the only possibility here is organophosphorus. Organophosphorus are cholinergic drugs, and they will cause all secretions to increase. All secretions will increase and ultimately there will be muscle paralysis. So we are looking at a case of organophosphorus poisoning. First we have to make a diagnosis. So we look at pinpoint pupil, opium or organophosphorus or phenol or pontine hemorrhage. If all secretions are rising along with meiosis, only OP poisoning is possible. So we have made a diagnosis that the patient is suffering with OP poisoning. Further diagnosis. How a diagnosis of OP poisoning is made? Number one, mostly the diagnosis is clinical, based on clinical symptoms. As I have explained, what lab test can be done? We can measure choline esterase activity in RBC. Choline esterase activity in RBC can be measured and this will be decreased. This will be decreased. The normal value is above 1000. In the question, as you can see, it is given as 50. So RBC choline esterase value is decreased. That means choline esterase in RBC is low. That can be done by organophosphorus. So that is the importance of RBC esterase value. It is used for diagnosis of organophosphorus poisoning. Coming to the treatment. If you are asked what is the first thing to be done, please write decontamination. Remove any clothing that patient is wearing and wash his body. Decontamination, because these drugs organophosphorus can also be absorbed via skin, so decontamination has to be done. Drug of choice for organophosphorus poisoning is IV atropine. IV atropine is the drug of choice. Till when atropine should be given? Till atropinization is confirmed. Atropinization signs are evident, and which is the best indicator of atropinization if asked? Then dried pulmonary secretions. Pulmonary secretions will dry and therefore the saturation of oxygen in blood will go up. So that is the best indicator of atropinization. You have to continue giving atropine every 10 minutes till the SpO2 starts rising. And then muscle paralysis. Muscle paralysis cannot be reversed by atropine. Atropine cannot reverse muscle paralysis. So if the patient is having continued muscle paralysis, then AIIMS are indicated. Pralidoxim or diacetyl monoxim, they are indicated to treat mainly skeletal muscle or diaphragmatic paralysis, because this is a nicotinic symptom and atropine cannot reverse it. So this is the treatment. Decontaminate, give atropine multiple times, and if needed, if there is diaphragmatic paralysis, continuing muscle paralysis, give AIIMS. So this is what the question is asking. I think the treatment is simple. Answer is B, atropine. Next question, all of the following can cause meiosis except we have already discussed. Organophosphorus cause meiosis. Morphine is an opioid, causes meiosis. Pilocarpine is a cholinergic drug, cholinergic drug, causes meiosis. Belladonna is atropine, which will cause mydriasis. It's an anticholinergic that will cause mydriasis, so answer is option number B. Pauci bacillary leprosy. Now this is based on recent changes in guidelines. So what is the treatment of leprosy now? So whether it is Pauci bacillary or multibacillary, treatment is with the same drugs, only the duration is different. So what is to be given and how it is given in the national program? Day 1. Day 1 means first day of every month for that patient. Whenever we are starting his treatment, first day of the month, he comes to hospital and under supervision. Under supervision means in front of the healthcare worker, he will take rifampicin 600 milligram once in a month. Then he will take clofazimine, half of rifampicin, so 300 milligram once a month he will take. And third drug he will take in front of the healthcare worker will be dapsone. Dapsone he will take 100 milligram. So these three drugs he will take on day 1 in front of healthcare worker. Then he will be given the remaining blister pack for to be used in the remaining days of the month, day 2 to 28 at home. That means himself he will take, and what he will take? He will take daily dapsone. So dapsone he will take 100 milligram daily, and half of it he will take clofazimine, half of it, that is clofazimine 50 milligram daily. So these two drugs he will take on the remaining days of the month at home. So we are giving three drugs, rifampicin, clofazimine and dapsone. In this manner, if he is suffering from Pauci bacillary, then the duration of treatment is 6 months, and if he is suffering from multibacillary, then duration of treatment is 12 months. That is the only difference as per the latest WHO and national treatment guidelines. So now there is no separate treatment of Pauci bacillary, only the duration differs 6 months or 12 months in leprosy treatment. So we are giving three drugs for 6 months. So option number C is the correct answer to this question. Question number 7 was a relatively straightforward simple question which has been asked many times. Patient was scheduled for surgery. Before anesthesia, he was given glycopyrrolate. Now, glycopyrrolate is an anticholinergic drug. It's an anticholinergic which is water soluble. It is water soluble because it is an ionized compound. So a commonly written word is, it is a quaternary ammonium compound, NH4 plus. It has a charge on it, quaternary ammonium compound, so it cannot cross blood-brain barrier. These are the 3 points in glycopyrrolate. It's a peripherally acting anticholinergic basically, and it is given before anesthesia to decrease laryngeal secretions and decrease laryngospasm. So it is used as a pre-anesthetic medication. That is the use of glycopyrrolate. So you can see that option number B, to decrease secretion, is the answer. Now here it is important to mention that atropine can also be used as pre-anesthetic, but the use has gone down because atropine can cross blood-brain barrier and produce CNS effects also. So the use has gone down, but it does not mean that atropine cannot be used for pre-anesthetic medication. Glycopyrrolate is more preferred nowadays. Question number 8 is based on a relatively new drug, pegloticase. So pegloticase is basically used for chronic gout. How does this drug act? So what happens, we have uric acid. Uric acid can be converted into a substance known as allantoin by an enzyme known as uricase. So uricase enzyme can convert uric acid into allantoin, and allantoin is soluble in water or urine, so easily excreted. So that is the property of uricase enzyme, to convert uric acid, insoluble uric acid, into soluble allantoin, so it can be excreted easily in urine. But this uricase enzyme is present only in birds. This is not present in humans. So what we have done, we have made recombinant uricase enzyme. So we took the gene from birds, put this in E. coli and produced the recombinant uricase, that was known as Ras-B uricase. So the name itself is self-explanatory. It is a uricase taken from birds and recombinant, Ras-B uricase. This was the first molecule that was developed, and this was given intravenously daily. This is an intravenously given drug and given every day. Then further modifications were done in this Ras-B uricase. It was added to polyethylene glycol known as pegylation. Pegylation means addition of polyethylene glycol. Polyethylene glycol was added to uricase enzyme and the drug becomes pegloticase. Pegloticase is simply pegylated uricase, and whenever we add polyethylene glycol, the size of the molecule becomes larger, and when the size of the molecule becomes larger, the renal excretion decreases, so the drug becomes longer acting. So this drug has a longer T half than the simple Ras-B uricase, and it is given once IV, one injection in 2 weeks, once in 2 weeks. So it is a longer acting uricase. So uricase, Ras-B uricase and pegloticase. Coming to its use. So patient has chronic gout. Patient has chronic gout. If you are asked what is the drug of choice for this chronic gout, then xanthine oxidase inhibitor drugs, xanthine oxidase inhibitor like allopurinol, or there is a new drug febuxostat. These are the two oral xanthine oxidase inhibitor which are drug of choice for chronic gout. So you will either give allopurinol or febuxostat as drug of choice for chronic gout. However, if gout is refractory, not controlled by xanthine oxidase inhibitor alone, then you can add few other drugs. What are add-on drugs? Number 1, you can add uric drugs like probenecid, or you can add the Ras uricase or pegloticase. So as is clear, Ras uricase or pegloticase are not drug of choice for chronic gout. they are used only as add-on to allopurinol in resistant cases. These drugs are given intravenously. Probenecid can be oral, but rasburicase, pegloticase are intravenous. So that is about pegloticase and the treatment of chronic gout. Question number 9. Non-pulsatile dose of GnRH agonist is used in all of the following conditions except. So what is GnRH agonist? That is number one thing to understand. What is pulsatile use? What is non-pulsatile use? So we have hypothalamus in our central nervous system. This hypothalamus secretes GnRH, gonadotropin releasing hormone. These drugs come to pituitary. And they will stimulate pituitary to cause secretions of gonadotropins, which are basically LH and FSH. These gonadotropins will stimulate gonads, that is testis in males and ovary in females. So this is the axis. Gonadotropin releasing hormone cause release of gonadotropins, and gonadotropins stimulate gonads. Now physiological secretion of gonadotropins from hypothalamus is pulsatile, or what we call as circadian rhythm, diurnal variation. Their secretion is high in the early morning and decreases throughout the day, then again increases. So there is a diurnal variation in their secretion from hypothalamus. If they are secreted in this pulsatile manner, they stimulate pituitary. However, if they are present in continuous or a sustained level in the body, then they will have the opposite. They will suppress pituitary function. So that discovery was made, that continuous or pulsatile will stimulate pituitary, while the continuous or sustained presence will suppress pituitary. Based on this, we can have the pulsatile or non-pulsatile administration of gonadotropins for treatment of various conditions. So let's now come to their uses. So pulsatile gonadotropin, let's look at their use first. Pulsatile gonadotropins, as we have discussed, when we give them pulsatile, they will stimulate pituitary and pituitary will secrete gonadotropin. So gonadotropin secretion will be stimulated. In males they will act on testes, in females they will act on ovary, and the testicular or the ovarian function will go up. So what are the possible situations which can be treated by giving pulsatile GnRH? Number one, delayed puberty. Delayed puberty. They will give GnRH pulsatile, it will stimulate gonadotropins which will stimulate gonads, and symptoms of puberty will appear. Secondly, an ovulatory infertility in females. An ovulatory infertility, gonadotropins FSH LH will stimulate ovary to cause ovulation, and we can treat. And third, they can increase testicular stimulation that can result in spermatogenesis also. So these three situations or diseases can be treated by giving pulsatile GnRH. However, if we were to give continuous GnRH or sustained non-pulsatile then we will see suppression of gonadotropin release from pituitary. and therefore the testicular and ovarian function will also cease. This is used, number 1, in treatment of cancers. Hormone dependent cancers can be treated. So in males, the hormone dependent cancer is prostate. So we will give continuous GnRH. They will decrease FSH LH release from pituitary, which will suppress testicular function. So testosterone release will decrease, and prostate growth is dependent on testosterone, so it will cease or reduce. So prostate cancer can be treated in males. Similarly, breast cancer in females is estrogen dependent, that can be treated. So these are the two cancers where GnRH can be given in continuous or non-pulsatile manner. Secondly, some gynecological diseases which are dependent on hormonal, particularly estrogen, like uterine fibroids, endometriosis, they are also hormonal dependent. We decrease the ovarian stimulation, estrogen production decreases, we can treat these conditions. And third, when there is precocious puberty. So puberty in males below 9 years of age is known as precocious puberty, and they will decrease the appearance of precocious puberty or the symptoms of it, and they are drug of choice for this condition. Precocious puberty, GnRH agonists are drug of choice. So these are the non-pulsatile uses of GnRH agonist. Let's look at what is given in the options. Non-pulsatile or continuous can be used for all of the following, except I think male infertility can be easily ruled out. In male infertility, we want to increase spermatogenesis, so we will give it pulsatile manner, not in non-pulsatile. Rest of the uses we have discussed. Question number 10 is an extremely simple question. Most commonly used route of administration of heparin for post-operative thromboprophylaxis. Heparin, the most common use is always subcutaneous. Heparin is given by subcutaneous administration, whether it is unfractionated heparin or low molecular weight heparin. The subcutaneous route is the most preferred route. Only in such few rare cases it can be given IV, but the commonest route is subcutaneous. So there is nothing much to discuss there. All of the following can be used to decrease intraocular pressure in glaucoma, except. Now this is also a very simple question, but some again I think in the exam anxiety some students have attempted this also incorrectly. The answer is pretty simple. What we need to remember here is that corticosteroids, particularly glucocorticoids, if we look at their ocular side effects, so if we try and write the ocular side effect of giving glucocorticoids, then we have to take into account the route. So if we are giving systemic, oral or IV, by systemic route, then they cause cataract in eye, posterior subcapsular cataract. But if we are giving corticosteroids directly in eye, topical as eye drops for various inflammatory condition, then they can cause increase in intraocular pressure. And this maximum increase by steroids is done by a steroid known as dexamethasone. So dexamethasone, if put in eye, will cause rise in intraocular pressure. So that is very obvious, this drug cannot be used for treatment of glaucoma because it is causing glaucoma. So dexamethasone is the answer to this question. Rest of the options, mannitol is used in acute glaucoma, attack of glaucoma or acute congestive glaucoma or narrow angle glaucoma. There is a controversy, however. If you are asked drug of choice for this condition, earlier mannitol was considered the drug of choice. Now all guidelines mention acetazolamide. So acetazolamide is the first drug to be given in cases of acute glaucoma. Mannitol is reserved for severe or resistant cases. So mannitol is used in acute glaucoma, but the first drug nowadays to be given is acetazolamide. Methazolamide is a type of acetazolamide, same carbonic anhydrase inhibitor. Clonidine, although clonidine itself is not used very commonly in glaucoma, but apraclonidine and brimonidine alpha 2 agonists decrease IUP, so it can also be used in theory at least. Question number 12. Like all opioids, tramadol act as analgesic drug by stimulating mu. Instead of mi, it should be mu opioid receptor. Apart from this, the additional mechanism of action of tramadol. So tramadol is an atypical opioid. There are two mechanisms. It is a mu agonist. Mu is a type of opioid receptor. It's an agonist on mu, but it is a weak mu agonist. It's a weak agonist of mu. It does act on mu, but not very strongly, not as strongly as morphine. In addition, this will inhibit reuptake of monoamines. It will inhibit reuptake of amines, which amines it will not allow to be reuptaken: serotonin more than noradrenaline. So it will inhibit reuptake of both, but if you are asked to choose one out of the two, it has more action on serotonin. So it is an atypical opioid. Acting by two mechanisms: mu stimulation and inhibition of reuptake of serotonin and norepinephrine. How does this norepinephrine reuptake inhibition or serotonin reuptake inhibition help in pain control? So if we look at a pain pathway, then we have a sensory nerve which brings the impulse, pain impulse, to spinal cord. So the sensory nerve is stimulated by trauma, and prostaglandins are produced which stimulate the sensory nerve. The impulse is carried to spinal cord, dorsal horn cells of spinal cord. From spinal cord, the impulse is carried upwards in the spinothalamic tract. This is thalamus. And from thalamus, the impulse goes above to cortex, where the procession, the final processing of the pain impulse occurs. This is the pain pathway. If we look at various analgesics, then non-steroidal anti-inflammatory drugs, NSAIDs, decrease prostaglandin production in periphery and also in spinal cord. So less prostaglandins means less inflammation, and therefore they are very good drug for inflammatory pain. So NSAIDs are very good at relieving inflammatory pain. That is the mechanism of NSAIDs. Now coming to opioids, we have mu, kappa and delta receptors, out of which mu is the most important. So I will show only mu in the diagram. So mu receptors are present in spinal cord and at supraspinal levels. So mu receptors are present in spinal and supraspinal structures like thalamus and cortex, and stimulation of these spinal as well as supraspinal by opioids causes pain relief by opening some potassium channels, causing hyperpolarization of the spinal and supraspinal neurons. So opioids are agonist at mu, kappa and delta at spinal and supraspinal levels. Now comes the role of tramadol. Tramadol, in addition to this mechanism, is also inhibiting the reuptake. It is inhibiting reuptake of serotonin and Na. So level of 5-HT and Na goes up in spinal cord and supraspinal level, and they cause the inhibition of nociception at mainly spinal level. So whenever serotonin increases, it causes inhibition of pain perception at spinal level. So that is also involved in the pain control by tramadol in addition to opioid. So it has two mechanisms, mu-agonist and reuptake of amines, serotonin more than Na. What is important to remember here is why this question is asked. We have naloxone, which is an antagonist or blocker at mu. It is a mu antagonist, naloxone, opioid antagonist. So it can only block mu receptor, it cannot prevent action of serotonin or Na. So analgesic action of tramadol will not be completely blocked by naloxone. That is the importance of knowing this additional mechanism of tramadol. Because it is acting via two mechanisms, so analgesic action will not be completely abolished by opioid agonist naloxone. Question number 13. A nurse gets accidental prick. So there is a needle stick injury from the HIV infected needle. Which of the following statement is false regarding the management of this nurse? So we are asked basically post exposure prophylaxis of HIV. Exposure has occurred and we want to prevent the development of disease. Post exposure prophylaxis. What are the steps? Number 1, wash with soap and water. This is a standard antiseptic procedure, nothing specific about it. Patient comes to the narco center or wherever the testing of HIV and dispensation of drug is given. Perform viral or HIV markers. Basically ELISA or rapid test is done. Why this is done? To establish baseline status. It is imperative to know whether at the time of prick patient was HIV positive or not. Maybe that in this case, suppose this nurse was already having HIV from previous. How do we know? So we need to know that at the time of prick the patient is HIV positive or not. Mere prick would not cause HIV positivity in few hours. So we need to establish the baseline status of the patient and therefore we perform the HIV markers or the ELISA test. Third, if the baseline ELISA is negative, that means patient is not HIV positive at the time of prick, then you start post exposure prophylaxis. Start post exposure prophylaxis. If patient, suppose patient can be HIV positive or negative after this testing. If patient comes out to be HIV positive, then you are looking at a case of HIV positivity, you need to give the treatment, not prophylaxis. So therefore, if HIV ELISA performed at the baseline is negative, then we are trying to prevent the development of disease after prophylaxis. So start post exposure prophylaxis if baseline HIV ELISA is negative. Prophylaxis will depend on the level of exposure as per the NACO guidelines. So if there is a low risk exposure, like needle stick injury, it is a low risk exposure, the chances of transmission of HIV is very less with needle stick injury, then what we will give? We will give 2 NRTI. 2 NRTI, and preferred combination is a lamivudine plus tenofovir, or you can give emtricitabine in place of lamivudine plus tenofovir. So 2 NRTIs are to be given in cases of low risk exposure. Tenofovir plus emtricitabine or lamivudine is the preferred option. However, if there is a high risk exposure, like direct contact with blood or blood transfusion, then we have to give 2 NRTI plus 1 protease inhibitor, So we can give tenofovir plus lamivudine plus any protease inhibitor like indinavir. So this is the drug combination to be given for prophylaxis, low risk and high risk depending on the risk of exposure. The post exposure prophylaxis, you should start within 72 hours of exposure. So that is another important thing to keep in mind, that it should not happen that the healthcare workers is exposed today and comes to the center, HRT center, after a week, then we cannot start. We have to start within 3 days of exposure, and duration is 28 days. 28 days. Then repeat viral markers at 6 weeks. So for 4 weeks we will give the therapy, and after the therapy has ended we will repeat the markers to see whether we have been successful in preventing the HIV transmission or not. So that is essential to do. So this is how we have to approach a question of post exposure prophylaxis. Perform the baseline viral markers. If baseline HIV ELISA is negative, only then we can give prophylaxis, otherwise we have to give treatment. Prophylaxis will depend on the risk of exposure. Low risk exposure like needle stick, 2 drugs, 2 NRTIs. High risk exposure, add a protease inhibitor also. Duration is 28 weeks and we have to start within 72 hours of exposure. So now we can attempt this question. The first option says zidovudine is used as monotherapy in post-exposure prophylaxis. This is an absolutely wrong statement. Monotherapy is never advised, whether in treatment or prophylaxis. Washing hands is advised. This is true. Baseline need to be performed. Follow-up need to be done at 6 weeks. So B, C and D are true. A is false statement. Question number 14. Match the following. So we have various antibodies given and we need to match them. So omalizumab is an antibody. This is an antibody against IgE. It is an antibody against IgE and it is used for asthma. Severe uncontrolled asthma. Itolizumab is an antibody against CD6. CD6, antibody against CD6. CD6 is a T cell marker. CD6 is a T cell marker and this antibody itolizumab is used for psoriasis. So itolizumab has been developed by an Indian company known as Biocon. So that is why this drug has been asked. Otherwise, it's not a very popular drug in the overall management of psoriasis. You will not find it in any of the standard textbook. Internationally, this drug is not available. Daclizumab, mechanism is same as another antibody known as basiliximab. These both are antibodies against interleukin 2 receptor. They both go and block interleukin 2 receptor. Now, interleukin 2 receptor has one subunit that is known as CD25. So, CD25 is a subunit of interleukin 2 receptor. So, CD25 subunit of interleukin 2 receptor is the specific target. So, they bind to IL-2 interleukin 2 receptor, but where on interleukin 2 receptor, that particular site is known as CD25. So, you can say they are anti-IL-2 or you can say they are anti-CD25. Both are acting by the same mechanism. Basiliximab, please remember, is used as immunosuppressant. Basiliximab used as immunosuppressant to prevent graft rejection, mainly after renal transplant, while daclizumab was used for multiple sclerosis. But this drug has now been discontinued, it is no longer available, but still question has been asked. So, you need to remember daclizumab is used for multiple sclerosis if available, and basiliximab is commonly used as immunosuppressant, although both are having same mechanism. Last is belimumab. Belimumab is anti, or I will write here, it is anti-Bliss, B lymphocyte stimulator. So, B lymphocyte stimulator factor. It is an anti-Bliss antibody and it is used for treatment of SLE. Belimumab, belimumab, the fourth one given. So, now it is easy to match. Omalizumab is anti-IgE, so one is C. Itolizumab is anti-CD6, so it is A. Daclizumab is anti-CD25, so it is B. And belimumab is anti-B lymphocyte, so it is E. So, these are the drugs given and their combination. Now, there are many other antibodies which should be known and we will post a video about that, but here one important thing which is source of confusion should be known. What is that? Anti-CD6, some students have confused this with anti-interleukin 6. So, interleukin 6 is different and CD6 is different. CD6 is an antigen, as I have written on T cell, it is a T cell marker, and interleukin 6 is an cytokinin. Now, we have an antibody against interleukin 6 also. So, anti-IL-6 antibody is known as tocilizumab. Tocilizumab is an antibody against interleukin 6 and tocilizumab is used for rheumatoid arthritis and the juvenile arthritis. So, please remember CD6 is different, interleukin 6 is different. So, tocilizumab is against interleukin 6 and itolizumab is against CD6. Moving on to next question, question number 15. Which of the following is a clinical use of tefenoquine? Now, this question is based on recent drugs, and tefenoquine is the latest drug for treatment of malaria. So, what is this drug? In malaria, in the treatment of Plasmodium vivax, We have to give radical cure. Radical cure means prevention of relapse, and relapse is due to the hypnozoites or the exoerythrocytic stage. So Plasmodium vivax has got the sleeping forms or the hypnozoites present in liver, also called as exoerythrocytic stage, which can cause relapse of malaria. So if you want to prevent relapse, you have to kill the hypnozoites, and that is known as radical cure, that is to kill the hypnozoite. Now, which drug was so far available? The standard treatment so far available is primaquine. So primaquine is the standard radical cure, and primaquine is given for 14 days. So 14-day treatment of primaquine is given for radical cure of vivax as of now. Now we have this new drug known as tefenoquine. The drug has a mechanism similar to primaquine, but this drug has a much longer T-half. The plasma T-half is much longer than primaquine, so it can be used as a single dose. Instead of 14 days, we need to give just 1 day treatment, single dose radical cure of vivax. So that is what tefenoquine is used for. Again, this drug, if we look at its side effect, can cause hemolysis similar to primaquine, and that makes it contraindicated. That makes this drug contraindicated. Number 1, in pregnancy, because pregnancy is a physiological G6PD deficiency. In children less than 2 years of age, and in patients with documented G6PD deficiency. So in these kind of 3 groups of patients, this drug is also contraindicated. Tefenoquine, single dose radical cure. Radical cure means the drug is going to kill hypnozoites. So that is the clinical use of tefenoquine, radical cure of Plasmodium vivax. The drug has been discovered in the last year, in 2018. So it's a very new drug, and still we may not call it drug of choice. It is yet to be evaluated in longer term studies. Next is prucalopride. Options are not given correctly in this slide. It is simply a serotonin 5-HT4 agonist, also known as Prokinetics. 5-HT4 agonist or Prokinetics. Prokinetics are the drugs that increase gastric motility, increase the tone of lower esophageal sphincter. These drugs are known as prokinetics. Along with these two actions, prucalopride or 5-HT4 agonist also increase colonic motility. So they also increase motility throughout the colon. So 5-HT4 agonist, they are prokinetics. This is how they act. There are 2 types of 5-HT4 agonists that were available in market. One was cisapride, and the other one was tagacerod. So these were the two 5-HT4 agonists available, cisapride and tegaserod. Cisapride was used, its use was treatment of gastroesophageal reflux disease, and tegaserod was used for constipation type of irritable bowel syndrome. So constipation predominant irritable bowel syndrome. Both these drugs have got banned because of their side effects. So cisapride was causing too much QT prolongation and arrhythmia, and the drug has been banned because of this. Tegaserod was causing myocardial infarction because in addition to 5-HT4 it also stimulated 5-HT1B/1D that resulted in coronary vasoconstriction and MI or angina. So again this was banned. So this is the background behind the initial 5-HT4 agonist cisapride, tegaserod. Now we have developed new drugs in these categories which are available and used commercially. So mozapride is one such drug which is available commercially in place of cisapride, again for GERD, and prucalopride is the newer drug in tegaserod family, and this is again used for constipation predominant IBS, but it has no stimulation. It does not stimulate this 5-HT1B or 1D. So therefore this problem of MI or ischemic heart disease does not exist with prucalopride. So in short, prucalopride is a 5-HT4 agonist used for constipation, and it is a newer derivative of an earlier existing drug tegaserod. So 5-HT4 agonist is the correct answer. Now this is a reason and assertion type of the new pattern of AIIMS questions that have come up since the May AIIMS examination. So there is a statement given and there is a reason which is given to justify that statement. So what is the assertion or the statement? Assertion or the statement says, then in a patient admitted in hospital for community acquired pneumonia. So we are looking at treatment of pneumonia in a patient admitted to hospital. Combination therapy of beta-lactam and azithromycin is given. So this is the statement. We don't know whether this statement is true or false. Second, the reason why this is done is because the combination covers positive or gram-positive organisms and anaerobes. Now then we are asked whether statement is true, reason is true, both are true, and if reason is correct reason or not, and various options are given. In such kind of questions, first you need to independently verify whether the statement and its reason are true independently without each other. So first let's look at the assertion. In a patient admitted in hospital for community acquired pneumonia, they are saying combination of beta-lactam and azithromycin. So we need to first know the treatment of community acquired pneumonia. So we are looking at treatment of community acquired pneumonia. Now this treatment can be divided into two parts. Number one, OPD treatment, outpatient treatment, and inpatient, admitted patient treatment. In outpatient also there are two parts, patient healthy in last 3 months or patient not healthy in last 3 months. So two situations will arise within the outpatient treatment, that whether patient has taken antibiotics in the last 3 months or not. So if he has not taken antibiotic in the last 3 months, then we say he is healthy as far as the infections are concerned. Patient is healthy, no antibiotic in last 3 months, we can give this patient either doxycycline or we can give him azithromycin. So that is the treatment option for a previously healthy patient, OPD treatment. If patient is not healthy, that means he has consumed antibiotics in the last 3 months, he is not healthy for our discussion, we can give him either combination of azithro, AZ represents azithro, plus beta lactam. So either we can give him this combination, beta lactam like amoxiclav can be used, amoxicillin clavulanic acid combination, or instead of this we can give him respiratory fluoroquinolone like Gatiflox, Moxiflox, Levoflox, respiratory active fluoroquinolone. So either azithro plus beta lactam or respiratory fluoroquinolone alone. This is the treatment of OPD treatment of previously unhealthy patient presenting with community acquired pneumonia. Now come to IPD, inpatient treatment, patient who are admitted. Again we have to see patient admitted in ward or in ICU. So in this also there are going to be two types. Patient got admitted in ward or he is more sick requiring ICU admission. If he is admitted in ward, then the same as the OPD, combination of this or respiratory fluoroquinolone can be given. If patient however is admitted to ICU, then we have to give beta lactam. Beta lactam has to be given. Along with beta lactam, we can either give azithro or respiratory fluoroquinolone. So now beta lactam become compulsory. Along with that, you have to give either azithro or respiratory fluoroquinolone. So the question says that in a patient admitted in hospital, so we are looking at IPD, combination therapy of beta lactam and azithromycin is given. We can see that combination of beta lactam and azithromycin is given. So the statement is a true statement. So the statement is true. Now comes its reason. This combination covers gram positive and anaerobes. So you see beta lactams like amoxiclav, amoxicillin, ampicillin, they cover gram positive, and if there is an extended spectrum like amoxicillin or piperacillin, they can even cover gram negative to some extent. Azithromycin is added to cover mainly atypical bacteria like chlamydia and mycoplasma. So out of these two combinations, none of the drug is very effective against anaerobes. So this reason is false. So now that we have independently assessed that assertion or the statement is true, but the reason is a false, now we can look at the options. Both assertion and reason are true, and reason is correct explanation of assertion, this is wrong statement. Both reason are true, this is wrong. Assertion is true but reason is false. Option number C is the correct answer to this question. So these kind of questions take comparatively longer time to solve, comparatively difficult to solve, and only if you have a complete knowledge about that topic, then you should attempt these questions. Question number 18, it has 5 statements and true or false. Independently we have to assess whether each statement is true or false. Now viral infection drugs are given, and we will see that out of these 5 statements, option number E, oseltamivir, is used for swine flu or influenza. Swine flu is influenza. So you see for influenza, let's take influenza first. The drug of choice is a class of drugs known as neuraminidase inhibitors. Neuraminidase inhibitors are the class of drugs or drug of choice for treatment of influenza, and two important neuraminidase inhibitors are oseltamivir, O for oral, it is given orally, known commonly as Tamiflu. 5-day treatment is given. So number 1, oseltamivir is used for swine flu. For 5 days it is given. Second drug is zanamivir. This drug is given by inhalation. Again it is given for 5 days. Third drug is paramivir, P for parenteral. So this drug is given intravenously, single dose intravenously. And the latest drug in this family is leninamirv, which is inhalation like zanamivir, but again single dose. So neuraminidase inhibitors, there are 4 molecules in that class: oseltamivir, zanamivir, paramivir, leninamirv. All these are used, and oseltamivir or Tamiflu is generally considered drug of choice. So option number E is a true statement. It's a true statement. Now we come to option number D, cimepravir inhibits protease. Option number B is ombitasvir is an inhibitor of protein synthesis, and option number A is ribavirin sofosbuvir. A, B and D all are related to hepatitis C treatment. So we have to understand the treatment of hepatitis C. Hepatitis C treatment. So what has been the standard or the conventional treatment so far? That has been a combination of interferon alpha, which are given by subcutaneous injection, plus ribavirin, which is an oral drug. This has been the standard treatment for many decades for hepatitis C. We give injection in the form of interferon and oral ribavirin daily. The treatment continues for 12 weeks, 24 weeks, depending on the condition and the genotype of the virus. Now we have developed several new oral drugs for Hep C. And they are very commonly asked. Now they are divided into 3 types, and all of them are oral. Protease inhibitor. So we generally study protease inhibitor in HIV, but these are protease inhibitors of Hep C. Initial drugs were cimepravir, talapravir. There is a new latest drug in this family known as paritapravir. So all pravirs are protease inhibitors. So protease inhibitors of hepatitis C end with pravir: cimepravir, bosipravir, talapravir, and the latest one is paritapravir. Then there is a Hep C it's an RNA virus. So Hep C RNA polymerase inhibitor. Those drugs that will inhibit the RNA polymerase, the RNA synthesis in hepatitis C, known as RNA polymerase inhibitor of hepatitis C, and these drugs will end with buvir. So we have two drugs here. First was sofosbuvir, and a newer member in this category is dasabuvir. So these are two molecules. These are two molecules which are sofosbuvir and dasabuvir, which are RNA polymerase inhibitor of hepatitis C. And the third class of drugs which have been developed are NS. NS stands for non-structural 5A inhibitors. So NS5A is a protease which is involved in, again, RNA synthesis. This enzyme NS5A is a hepatitis C enzyme present in hepatitis C, and it is also indirectly involved in RNA synthesis of hepatitis C, NS5A. So we have developed drugs which inhibit this NS5A enzyme, and these drugs, the first drug in this category was ledipasvir, and a new drug in this category is ombitasvir. So they will end with asvir. All these drugs will end with asvir. So we have buvir, asvir and pravir. These are three new types of oral drugs for hepatitis C. So this is what the new drugs are all about. Last thing, the standard treatment I have told you. Nowadays we have developed complete oral treatment of hepatitis C, getting rid of injections of interferon. So combinations like sofosbuvir plus ledipasvir or sofosbuvir plus declatasvir. Many other such combinations are now available for treatment of hepatitis C, and as you can see, these combinations are interferon and ribavirin free. Number one, they are completely oral and they have been found to be highly effective. So complete oral treatments have come up, getting rid of the need of interferon and even avoiding ribavirin. So these are the new developments in hepatitis C, and with this background we can attempt the options. Treatment with ribavirin is considered better than sofosbuvir. As I have told you, sofosbuvir based combination are replacing ribavirin based combination, so this is false statement. Sofosbuvir based are better, highly effective than ribavirin based. Ombitasvir, if you will recall, here it is ombitasvir, NS5A inhibitor. NS5A is involved in RNA synthesis, not in protein synthesis, so this option is also false. Cimepravir inhibits protease. This is a true. Pravirs are protease inhibitor. We are left with imiquimod and condyloma acuminata. Human papilloma virus can cause anogenital warts, also known as condyloma acuminata. So they are genital warts caused by HPV. What is the treatment of these? Non-pharmacological treatment, cryotherapy. If there are mild superficial lesion, cryotherapy is best. As far as drugs are concerned, topical gel are available of imiquimod. So it is the topical application of imiquimod which can be done, and imiquimod act as an immunostimulator. It stimulates T cells. We call it immunomodulator, but basically it is an immunostimulator. It stimulates T cells, causes the local clearance. And in severe cases, severe or refractory warts not responding to the above two therapy, you can give intralesional injections of interferon alpha can be given. So interferon alpha is a highly effective but expensive, and there is injectable therapy, so it is reserved for the severe cases. So condyloma acuminata is treated by imiquimod, topical imiquimod. So this option C is also true. So this is about question number 18. There are 5 statements all related to viral diseases, so we have to approach them one by one. So in one question we have covered influenza, hepatitis C and human papilloma virus. Question number 19 is relatively simple question. Drug of choice for bacterial vaginosis in pregnancy. Whether pregnancy or not, for bacterial vaginosis the drug of choice remains the same, and it is metronidazole. Even in pregnancy or without pregnancy, bacterial vaginosis, it is same. The alternative to this is clindamycin. The drug of choice is metronidazole, whether in pregnant or in non-pregnant cases. Question number 20, G protein coupled receptor that does not act through opening of potassium channel is. This is a difficult question based on some relatively recent discovery, normally not asked, and we will have to discuss from beginning of G protein coupled receptor. So you see, what is a GPCR we need to understand. This is a cell. On the surface of cell there is a receptor which is very long, so it is folded 7 times into the membrane. On the outside we have the agonist binding site. Agonist will bind outside the cell. Inside the cell, this receptor, the long serpentine receptor, is attached to a G protein. Let's say this is G protein. What does the G protein look like? This G protein has an alpha subunit and it has a beta and gamma. So alpha remains alone and beta gamma are combined. Whenever this receptor is stimulated by agonist, what happens? This alpha unit will dissociate. The alpha unit is normally attached to GDP. The moment agonist will bind, GDP will be replaced by GTP. So agonist binding replaces GDP with GTP and there will be dissociation. The alpha unit with its GTP will dissociate and beta gamma unit will dissociate. They too will dissociate. Normally GPCRs are discussed in relation to this alpha unit, what alpha unit can do, and that is normally what is asked. So this alpha unit attached to its GTP can do 3 things. Number 1, this alpha unit can activate represented by positive stimulation adenyl cyclase enzyme. Adenyl cyclase enzyme. When adenyl cyclase is stimulated, cyclic AMP will increase in the cell, and this is known as G stimulatory kind of GPCR, GS. This alpha unit can do another thing. Instead of activating or stimulating adenyl cyclase, it can inhibit adenyl cyclase, and that will decrease cyclic AMP in the cell. This is known as GI kind of GPCR. And third thing this alpha subunit can do, it can activate another enzyme known as phospholipase C, and that will increase IP3 and DAG inside the cell. This is known as GQ. IP3 will further increase the intracellular calcium. So based on alpha subunit activity, GPCRs have been traditionally classified into GS, GI and GQ, and this is what has been asked so far in the exams. Not much emphasis has been placed on this beta gamma unit. What can this beta gamma unit do? Now this beta gamma unit can directly open certain ion channel. It was known from the very beginning, but not much research or information was available. Which ion channel? So this unit can go to a, let's say, a calcium channel, and it can open that calcium channel, so calcium can come inside the cell. So it can open certain calcium channels. In addition to that, this can go and open some potassium channels. And whenever potassium channel will open, potassium will go outside because it is more inside the cell. So this beta gamma subunit, in addition to acting on calcium channels, it can directly open some potassium channels also. And as I have told you, whenever potassium channel will open, potassium will move outside the cell. So it will be hyperpolarization that will occur. And such kind of potassium channels which are directly opened by beta gamma subunit are known as G protein. G protein regulated inward rectifying potassium channel, and that is what question is asking. In short, they are referred to as G protein regulated inward rectifying potassium channel. Now their presence was known from a very long time, but the examples and much discovery has happened in relatively recent past, and that is what question is asking, that which type of GPCR do not act via opening potassium channel. So which are the receptors which are related to GERK or G protein related inward rectifying potassium channel? So you need to make a list and remember it. Number 1, muscarinic type 2, muscarinic type 2, alpha type 2, in serotonin 1 receptor. So this is muscarinic and alpha in autonomic system, in serotonin 5-HT1, then in GABA type B receptor, not a GABA type B. Then we have some somatostatin receptor, then we have the P2Y. If you will remember, they are adenosine receptor on platelet ADP receptor antagonist drugs like clopidogrel we have discussed. So P2Y type of adenosine receptor, they are also having this G protein regulated inward rectifying potassium channels. Cannabinoid CB1 and CB2 cannabinoid receptors. So these are some examples of receptors which are related to potassium channels opened directly by the beta gamma subunit of GPCR known as G protein regulated inward rectifying potassium channels. And also I forgot, here we should write the dopamine type 2 receptors. D2 receptors are also part of this list, D2 receptors. So now that we have understood the importance of beta gamma subunit of GPCR, and we have also seen the GnRH type of potassium channels and which receptors are related to GnRH, answer is very simple. Angiotensin 1 receptor is a GQ type of GPCR, not related to potassium channel. Rest 3 are related to opening of potassium channel. 21. The question is giving a drug tedizolid. Tedizolid reminds us of a more commonly used antimicrobial, linezolid. Linezolid and tedizolid both belong to the same class of antibiotic, and the class name is oxazolidinones. So oxazolidinones is a class of antibacterial drugs, of which the first member is linezolid. So we can start writing the main points here. Linezolid, it is a protein synthesis inhibitor drug, inhibits protein synthesis. Protein synthesis inhibitors are bacteriostatic. They bind to 50S, and in 50S also they bind to its 23S part. So 23S of the 50S, and they will inhibit the initiation. Normally initiation is inhibited by binding to 30S. These are the only class of drugs that inhibit initiation of protein synthesis after binding to 50S. So that needs to be remembered. Drugs are bacteriostatic. On which kind of bacteria do the drugs act? What is the antibacterial spectrum? So mainly they are for gram positive bacteria. Resistant gram positive bacteria like MRSA, VRSA, vancomycin resistant Staph aureus, and vancomycin resistant Enterococcus. So they are mainly to treat resistant gram positive infection. Their uses includes resistant skin infections, IXS infections, community acquired pneumonia. So these are two important uses, obviously caused by gram positive organisms. Skin infections, community acquired pneumonia, sometimes GI infections also, but caused by gram positive organisms like MRSA or VRSA. The side effects, if we enumerate, the common side effect of these drugs are GI disturbances, GI disorder like diarrhea. So that is what is the common problem with linezolid. On prolonged therapy, on prolonged treatment, some additional side effects can become apparent. What are these additional side effects? Number 1, bone marrow suppression can occur, particularly thrombocytopenia can occur, peripheral neuropathy can occur, and lactic acidosis. So these three problems are seen only on prolonged use. They are not very common problem. So this is about linezolid. Now we come to the drug in question, tedizolid. Tedizolid mechanism is same. as linezolid, spectrum is same, use is same. Now there is one difference. Linezolid, denoted by L, is given mostly orally, 600 milligram twice daily. So linezolid is given twice a day, mostly orally. Tadezolid, denoted by T, is again given orally, 200 milligram once daily. So it's a longer acting drug than linezolid. So that is number one difference, longer acting. Both are given orally. So their oral absorption is decent. They have excellent oral absorption, no problem there. Coming to side effects, the bone marrow suppression is less and peripheral neuropathy is less with tadezolid as compared to linezolid. So these are the differences between tadezolid and linezolid. With this we can approach the options. Which of the following is true about tadezolid? Peripheral neuropathy is a common problem. This is false. It is a relatively uncommon problem, especially with tadezolid. Active against gram positive, this is true. Poor oral bioavailability, this is false. These are orally given drugs. And major mode of elimination is renal, this is also false. These drugs, both tadezolid or linezolid, both are safe in renal impairment. Both of them are safe. They are metabolized in liver and the products can be excreted in urine, but they have no problem as far as renal impairment is concerned. We can give the normal dose. So the answer to this question, the only true statement is B. We come to question number 22, Z-track technique. So Z-track technique, this is a pretty standard question. Z-track is a type of intramuscular injection technique. Intramuscular injection. What we do in Z-track is very simple to understand. You have, suppose, the skin, the any part where you want to give the injection, and this is your injection. This is your needle. So you inject and you deposit the drug here. So this is an injection having the drug. You inject and deposit the drug here. When you remove the needle, what can happen is that the point of injection and point of deposition are in straight line. So some drug can diffuse back. From muscle it can come back to skin and this can cause skin pigmentation or irritation. What we do in Z-track, so if this is the area we want to give the drug, then we will stretch the skin. We will stretch the skin of this part. So you put your finger here, you stretch the skin, you give the injection. After stretching the skin, you give the injection, deposit the drug and then release. So what will happen? The skin that was stretched will come over it, so the track becomes something like this. The drug is not able to diffuse back. So that is the whole idea behind Z-track technique, that to decrease the back diffusion of drug into subcutaneous tissues, and this decreases the skin pigmentation and also decreases the skin irritation. So this is a intramuscular injection technique, can be given for any intramuscular drug. Commonly it is used for intramuscular or parenteral iron preparation, but if we look at the option, iron is not given, So let's take option one by one. Monitoring of lithium therapy. It is done by drawing intravenous sample. No role of Z-truck technique. Carbamazepine. Again intravenous sample. Blood sample is drawn. Administration of patch. Patch is a transdermal. So only possible option is administration of long acting. So long acting IEM preparations are given for antipsychotics. Also known as depot IEM injections. They are used for antipsychotics. And which antipsychotics? First was fluphenazine. Then we have developed it for haloperidol. Then for the newer atypical ones like olanzapine, risperidone, even paliperidone, aripiprazole, many others are available. Long acting intramuscular injections. They are given once in 21 days. Once in 3-week injection is given, and they are suitable for non-compliant patient. Patients who are non-compliant in their treatment do not take drugs daily. For these kind of patients, we can give long-acting or depot intramuscular injection by Z technique. Fluphenazine was the first. Then we have several new antipsychotic available as intramuscular injections. Then we have question number 23. Which of the following statement regarding foscarnate are true or false? So foscarnate is a drug used for treatment of herpes group of viruses. So herpes group of viruses, there are many, and we need to discuss the drugs and the viruses. So there are 3 drugs basically: acyclovir, ganciclovir, and foscarnate. 3 types of drugs are available for treatment of herpes group of viruses. How do acyclovir and ganciclovir act? First thing, we need to remember the mechanism of action of these drugs. So you write that acyclovir and ganciclovir both are inhibitors of DNA polymerase. DNA polymerase inhibitor. Remember, herpes viruses are DNA viruses, so they have DNA polymerase enzyme that is inhibited by acyclovir and ganciclovir both in a competitive fashion. So they are competitive inhibitor of DNA polymerase, while foscarnate is also a DNA polymerase inhibitor, but it is a non-competitive. So all 3 drugs are going to inhibit the DNA polymerase of herpes, but acyclovir, ganciclovir are competitive inhibitors, while foscarnate is non-competitive inhibitor. What is the importance of this word non-competitive? So then we need to go in details of mechanism. So what happens, whether it is acyclovir or ganciclovir, once you give these drugs, they go inside the cell and they acquire a phosphate. They become monophosphate. Which enzyme cause phosphorylation? We know kinase. So they require a kinase, and that kinase is thymidine kinase. So once inside the cell, intracellularly they are phosphorylated by thymidine kinase enzyme, and this has to be a viral enzyme. This is not a human thymidine kinase they require a viral thymidine kinase to become monophosphorylated, 1-phosphate. Then they will become acyclovir triphosphate. They will take 2 more phosphorylation by again kinase enzyme, but this kinase can even be human kinase enzyme. So they require first phosphorylation by a viral thymidine kinase. Once they become triple phosphate, they resemble a nucleotide and then they cause competitive inhibition of the DNA polymerase enzyme. That is how they are called competitive, because they first become a nucleotide and then they competitively inhibit the DNA polymerase. Phoscarnate, as told, is a non-competitive. You give phoscarnate, it goes inside the cell and directly inhibits DNA polymerase. No phosphorylation is needed. No intracellular phosphorylation is required by phoscarnate. So, if a virus, if a HSV, herpes simplex virus or cytomegalovirus, if a virus is thymidine kinase negative, TK negative strain, the virus, whether herpes simplex or cytomegalo, it has lost thymidine kinase enzyme, TK negative strain, then it cannot activate acyclovir or ganciclovir. So we are looking at acyclovir or ganciclovir resistance. So herpes simplex virus or cytomegalo can become resistant to acyclovir or ganciclovir by loss of thymidine kinase. Now which drug does not require thymidine kinase? As we can see, phoscarnate. So one thing is clear to us, that phoscarnate can be used for infections which are resistant to acyclovir or ganciclovir. So that is the basic purpose, the clinical significance of knowing this mechanism. So now we will write the uses of these drugs. Acyclovir is drug of choice for herpes simplex virus, whether type 1 or type 2. Herpes simplex type 1 or type 2, it is drug of choice, and it is also drug of choice for chickenpox. These are the 2 uses of acyclovir. The side effect of acyclovir, number 1, it can cause crystalluria, it can precipitate in urine, and it can cause some neurotoxicity. This is about acyclovir. Coming to ganciclovir, ganciclovir is considered drug of choice for cytomegalovirus. Cytomegalovirus causes CMV retinitis in HIV, so it is used for that. Now here there is a twist. We have a new drug known as ganciclovir added to an ester group known as val. So it becomes valganciclovir. Valganciclovir is a prodrug with higher oral bioavailability than ganciclovir. So if you are to choose between ganciclovir and valganciclovir, answer will be valganciclovir. The side effect of ganciclovir or valganciclovir is bone marrow suppression. Bone marrow suppression. So ganciclovir is drug of choice for CMV. Coming to phoscarnate, phoscarnate is used for resistant herpes simplex, acyclovir resistant herpes simplex, or it can be used for resistant CMV, ganciclovir resistant CMV virus. That is the use of phoscarnate. This drug is given intravenously. Side effects: nephrotoxicity is the dose limiting problem. Second, it's very important and interesting. It can bind cations. It binds to or it chelates cation, that leads to cation deficiency. So you can have hypo, various kinds of hypo can appear. Hypocalcemia can occur, hypomagnesemia can occur, hypokalemia can occur. So these kind of problems can occur, and one rare side effects which has now been accepted is the penile or vulval ulcers. This has been recently acknowledged as the new side effect of phoscarnet. So we have discussed everything that is there to discuss in herpes simplex virus and their treatment. Acyclovir, ganciclovir, phoscarnet. We are asked question about phoscarnet. I think with this background we can see which of the following are true. It is used for resistant CMV, that is a true statement. Renal toxicity is the main problem, nephrotoxicity. It is activated by viral thymidine kinase, this is false. Regular monitoring of electrolyte is needed, this is true. As I told you, hypocalcemia, magnesemia and all these. It causes genital ulceration. No book will mention this side effect, but as I have told you, it can cause, it has